So we're going to be talking about robotic surgery, specifically the Da Vinci robot. It's our soft tissue robot we have here at North Shore, utilized for abdominal and thoracic procedures. So the purpose of this is to provide essential information regarding the advantage of robotic surgery for our patients and the clinical practice of robotic surgery. We would like to increase staff awareness and understanding of the surgical robotic procedures. And as introduced before, myself will be speaking, Teresa and Diana. So what are we doing here at North Shore? At North Shore, we're doing GYN, urogynecology, general surgery, urology, bariatrics, oncology, cardiac, and colorectal surgery. This past few months, we've added hepatobiliary procedures. Hepatobiliary is looking to expand to transplant. So the program is growing and growing and growing. Last year in 2024, we did 608 robotic procedures. That was a big milestone for us. When I got into this role in 2019, we were doing about sub 300 procedures with the objective of growing the program for the benefit of our patients. So with a lot of effort from our team, we were able to grow it to 604 robots. With the growth of the program became the growth of our robotic fleet. What was one robot a year ago is now 3 robots this year, with the potential of expanding even more. What are our common most procedures here? Most common specific procedures: supracervical hysterectomy, sacral colpopexy with our surgeons from urogynecology. Second would be our bariatric procedures, so vertical sleeve gastrectomy, gastric bypass. And then recently, last year, we've seen a big increase in abdominal hernia repair, so incisional hernia repair, ventral hernia repair, umbilical hernia, any hernia in the abdominal wall. Great platform to repair with the robot. Before we can kind of discuss the robot, we got to think about how we got here, right? So 1901, Dr. George Kelling, he has this idea. How can I see inside an abdomen? How can I get inside of an abdomen without making a large incision? So he makes a small incision. He happens to make it on a dog, but that doesn't matter. And he does the world's first diagnostic laparoscopy using just a scope and one instrument. Not much changes between 1901 and 1969 until you get the development of the charge coupling device. This is when televisions were being mass produced. What does the charge coupling device do? It takes the image that is seen on a camera and projects it onto a monitor. So now Dr. George Kelling, he doesn't have to hold the scope with one hand and operate with the other. He can comfortably look at an image on a monitor and use 2 hands to operate. Around the 1980s, the US Army develops this concept of remote surgery. How can we perform surgery for our soldiers that are in harm's way without sending our surgeons over there? They kind of just come up with this idea and kick it out to the private sector. Around this time, Stanford Research Institute develops robotic telemanipulation for microsurgery. That is transferring the movements of a surgeon's hands through a device onto a patient. So that was one half of what we need to get to robotic surgery. The second would be with Scott Fisher at NASA in 1985. He develops telepresence. Telepresence is what we know today as virtual reality. So when our surgeons are sitting at the surgeon's console, the view of the camera makes it feel like they've been shrunk down and placed inside, and they're actually inside of the abdomen. Now, the concept of remote surgery comes into play in 2001. Team in Paris, they bring all the specialties into the OR. They have anesthesia, the patient, nursing, everybody. Day before, 2 surgeons fly to New York. Day of the surgery, patients in Paris, 2 surgeons sit at the console in New York, and they perform the surgery. I believe it was a robotic cholecystectomy on the procedure on the patient in Paris. Been done once or twice since then, but you can only imagine where we're going with this, right? Since the pandemic, what have we seen a huge increase in? Telehealth visits, Teams meetings. So how far are we away from the best surgeon in New York performing surgery on the richest guy in Thailand? Elon Musk shoots one of these things up to Mars, and we're performing surgery on astronauts in outer space. Interestingly enough, one of my friends just sent me an article about Johns Hopkins. They have just trained a robot, a Da Vinci robot, to perform basic procedures like suturing and things like that, only training the robot through the robot watching videos. And what they actually found out was things that they did not train the robot to do, the robot just kind of picked up on its own. AI picked up on its own. So when the robot dropped the needle, it went down and picked up the needle, loaded it the right way, and then continued on. So with AI, advancements in telecommunication, probably not that far away from seeing things like that happening. Once we got to 1985, you start to see companies producing these robots. So you can see over the years the developments of the robots. They started with a cranial robot, an orthopedic robot. 1995, Intuitive Surgical is developed or founded. That's who produces our robot right now. And then you get little things along the way. But as far as it goes for North Shore, 2004, North Shore brought on their first robot. And one of the members of the team that started the robotic program was Teresa Vigliano, and she's going to pick up on what kind of progress we've made here at North Shore.
So good afternoon, everyone. My name is Teresa Vigliano. I say Avellano, but I'll say it Vigliano. And I'm the robotic team lead. Nearly 21 years ago, I was given the opportunity and the privilege to be a part of something truly special, the development of our robotic program. What began as a small team of surgeons, nurses, and surgical technologists, can't hear me?
Make sure you have your camera on. Make sure you have your camera on for the clinical ladder.
Yeah, can you guys do us a favor? Can everyone just go on mute because we're hearing a little of you in the background?
Thanks, Ruby. Okay. Don't know if this one's working. Is this working? Okay, good. So what began as a small team of surgeons, nurses, and surgical technologists has advanced to a successful program brimming with a highly skilled team that encompasses a multitude of surgical disciplines. Just as our team has advanced over the years, so has our robot. S, SI, XI, and our newest addition, the DV5. To most, they're just letters in the alphabet. But to the surgical team, they represent generations, not the millennial or baby boomer type, but the robotic type. So the first and second generation, S and SI, were a clunky 1,200 pounds, cumbersome, very involved to drape, and even more involved to navigate. Whereas the third generation, the XI, is modern, sleek, has a movable boom, and is motorized, making it lighter and easier to manage. Well, at least one of us has managed to get lighter over the past 21 years. I have to add a little something. Amen. The fourth generation, the DV5, is even more refined. It has an even sleeker design with its touchscreen monitors and state-of-the-art, compact, futuristic console. By far the prettiest, most intuitive generation. But we are all still waiting for that wireless version. So my purpose today is to give a short overview of the robot and how it is an integral part of the team. So what is a robot? The word robot can conjure up many images and mean different things to different people. For some, the word robot could represent that crazy dance from the 1970s, or perhaps even that cute little R2-D2 guy from Star Wars, or even that round vacuum thingy that cleans the floors. All very valid images. But when you say robot to a surgical team, we think Da Vinci and surgery. There are three main components of the robot: the vision cart, otherwise known as the tower, the patient cart, otherwise known as the robot, and the surgeon console. Like everything else in medicine, communication is key. All three components communicate via fiber optic cables, which once connected to each other, allow the system to function as a unit. It is important to note the three components cannot function independently. So if there is a malfunction in any one of the components, it must be corrected in order to continue. And although our team is amazing at troubleshooting, we have a technical support team that are a phone call away. 1-800-876-1310, option 1. As you can hear, I've had to call it a few hundred times over the past 21 years. The tech support team has the ability to look directly into our system via an Ethernet cord and can tell us what the problem is and how to correct it. Technology is an amazing thing. Just as the components must communicate with each other, there are robot-specific instruments, scopes, and trocars that must be used. They cannot be substituted by any other instruments because they are designed to fit on the arms of the robot. Surgery cannot be performed without them. There is a full range of endo-wrist instruments available, and each has a specific surgical function. So I'm going to show you, this is an endo-wrist instrument specific to the robot. This one is a scissor, and the difference, laparoscopic versus robotic, linear versus endo-wrist. The endo-wrist instruments are unique because they were designed to mimic the motion of the wrist or 360-degree range of motion, thus making the endo-wrist instruments more precise, which extends the surgeon's surgical capabilities. The robotic endoscopes have advanced digital optics and are available in 0 and 30-degree lenses. The dual lenses and light are mounted on the tip of the scope, which allows for superior magnification and clarity. Most importantly, the scopes are three-dimensional and provide true-to-life images of the patient's anatomy. The vision cart, otherwise known as the tower, is the brain of the system. It houses the main components responsible for completing the communication between the robot and the console. The 3 fiber optic cables originate from the tower, and once connected to each component, provides the signal for transmission to all 3 pieces. So the tower provides the monitor with its picture for the surgical procedure. Although it's 3-dimensional for the surgeon, it's only 2-dimensional for those on the outside. The arms of the robot, it gives it the ability to move once they're connected, and the surgeon a 3-dimensional field and use of the hand pieces on the console. The monitor also provides us with pertinent information before, during, and after the surgery. For example, it displays the endo-wrist instruments in use or if there are any problems occurring. The tower also holds the robotic-specific cautery and vessel sealer components. The patient cart, otherwise known as the robot, is the heart of the system. It is the working element of the system. It has 4 arms that can move in multiple directions, and as mentioned previously, has specific endo-wrist instruments, scopes, and trocars designed to attach to these arms. It is motorized, giving it easy maneuverability for driving, and in the event of a power failure, does have a manual override and battery backup, but it must be plugged in at all times in order to maintain the battery's charge. It is the only component that must be sterilely draped because it is the only component that attaches directly to the patient. There is a touchpad display screen and controls to fine-tune the robot's position. Although all the components are highly intuitive, it is most obvious with the robot. It instinctively knows which direction the boom should spin based on what body part we have selected on the display pad. And it places itself over the patient to afford the surgeon the best working and visual field. We actually drive the robot over the patient, but the boom actually turns and knows where it has to go. We then place it with the assistance of Michael or the surgeon. to best afford the surgeon the best visual field. By the way, the robot does speak. She's not like Alexa, but she doesn't respond to voice activated commands, but she will say when she's ready or to move the arms and in a female voice. And if there's a problem, she alarms loudly and incessantly until the problem is addressed. Sound familiar? My kind of woman. The surgeon's consoles are the hands and eyes of the system. It contains a viewfinder, hand controls, and foot pedals, which communicate directly with the robot. When the surgeon places his head in the viewfinder, his view of the field is now three-dimensional, so it's as though he's looking directly at the open anatomy. Additionally, the high magnification of the robotic scope gives them amazing detail. The hand controls allow the surgeon to perform the operation. Simply placing the thumb and index fingers of each hand into the hand control pieces allows the surgeon the ability to move the arms of the robot and use the EndoWrist instruments and scopes that are attached to the patient to perform the surgery. The way it works is they place the ports laparoscopically. They put these trocars into the abdomen, and then the instruments slide through, attach onto the robot, and now the surgeon operates these instruments via the console while seeing it in a three-dimensional view. The console also has a built-in safety feature that only allows the hand controls to function if the head is in the viewfinder. Very important feature. We have two consoles which allow two surgeons to operate simultaneously. The console is also equipped with a mechanism that can point to anatomy for teaching purposes. What makes it unique and interesting is the surgeon is sitting at a console that is in one area away from the patient while operating on the patient in another area. Early in the presentation, I mentioned wanting a wireless generation. That would be because there are a multitude of cables and cords affiliated with the robotic system. There are three blue fiber optic cables that are responsible for the communication of the components. They must always be securely attached because if they become dislodged or damaged, the system can and will be impacted. It is important to avoid bending, stepping, or rolling over the fiber optic cables to ensure the integrity and the optimal functioning of the system. This is our robotic table. It is a mobile OR table designed to work with the integrated table motion with the robotic system. With the DV7000, the table can be paired with the robot, and even when the robot is attached to the patient, the table can be safely moved to different position for better access. With a standard operating room table, there can be no movement once the robot is attached. So in closing, the robot is a complex system that interacts with the humans on the team in an intuitive and highly sophisticated manner. Together, they form a team with undeniable benefits which are passed on to our patients. In the end, we have a happy surgeon, a happy team, and a happy patient. And anytime you have that type of trifecta, well, that makes for a great surgical experience. Thank you. So now Diana Carter will now take over and go through the roles of the technologist, surgical technologist, and a day in the life.
Can you guys hear me? Okay, good. So today we use the robot in general cases, GYN, urogyn, urology, And with cardiac and thoracic surgeries, for each case, we need to consider what is the patient's positioning, how steep are we going to go. Will we need supplies to accommodate the steepness, such as an anti-slip mat for the deep Trendelenburg of GYN cases, or a footboard for reverse Trendelenburg of bariatric cases, where the patient is basically standing. We need to consider that the patient's arm position, is it tucked or untucked, or is it lateral? The room is set up with the robot, tower, and typically 2 surgeon consoles, but the rest of the equipment is similar to a laparoscopic case. There needs to be some sort of insufflation, which is usually an air seal device or Olympus tower. There's a Bovie and sometimes an argon Bovie for cautery, and a Neptune and saline for suction and irrigation. In the beginning of the day, the nurse used to plug in all the machines and thread all the cords around the room to avoid hazards where people can trip or accidentally run over the damaged cords. And like Teresa said, there's 3 blue cords that come out of the robotic tower that connects the robot to itself and each console. These blue cords make the device work in sync, so if one is unplugged during the surgery, all connection is lost and it will disrupt the surgery. When there is an error on the robot, it will flash either orange, which is a recoverable fault, and it can be troubleshooted, and there's a non-recoverable fault, which is red, and the whole machine has to be rebooted. When all the lights are blue, the machine is ready to go, and we can go get the patient. And when interviewing the patient, we need to know their baseline, such as their medical history, allergies, and pre-existing physical and neurological deficits. If there are significant conditions found in this assessment, such as pulmonary and cardiac disease, anesthesia and the surgery team should already be aware and take precautions. When the patient enters the room, there's a lot going on. There's the robot, there's the lights, there's a lot of people and a lot of instruments, so it may be overwhelming. The cold temperature also doesn't help with the nerves, so we wear gloves for our protection, but also not to freeze the patient when we're helping them onto the bed, and immediately pile them with warm blankets. Once the sequentials and EKG monitors are all on, the nurse should stand to the patient's right if you are right-handed, so they can assist anesthesia with intubation and offer the dominant hand for cricoid pressure. After the intubation is confirmed in the correct placement, then the positioning can begin. The nurse, RNFA, residents, and anesthesian can help with positioning, but the surgeon is the one who oversees and confirms positioning to prevent any unintentional injuries. When we position the patient, we've had the IV sites to prevent skin injuries. If the arms are out, they should be positioned with palms up and less than 90 degrees to prevent nerve compression. We add pillows or gel rolls when needed, and we secure the patient to the bed either with a safety belt across the thighs or the chest. When the surgery is over, we take off all positioning aids except for the safety belt so we can lay them supine for extubation. The nurse should stand next to anesthesia and assist when needed. After extubated, anesthesia evaluates the patient condition and decides when it's appropriate to start transferring to the PACU with oxygen and monitor. For the role of the surgical tech, which is in this hospital, nurses can also be the role of. We need to maintain sterility and protect the surgical field, assist the surgical team and anticipate their needs, manage the surgical instruments and supplies, and dress the robot. Before the case, the surgical tech is responsible for collecting trays and robot arms and accessories needed for the corresponding case. There are 5 covers used to drape the robot, 1 column drape and 4 arm drapes. Each arm drape has 3 built-in connection sites that gets connected to the robot and 2 magnets on each arm to keep the drape in place. The middle column drape just has 1 magnet built into the drape. There is an off-site Da Vinci training that staff can be scheduled in to train with the robot while on orientation. After the formal training, the orientees are set up with preceptors who help them put these new skills to use. Robot accessories come with a lot of long wires and attachments, so they must be untangled and secured either with Velcro or clamps to the drapes so they don't fall off or accidentally get contaminated. The robot scope is very powerful light, so it must be monitored when not in use. The surgical tech can either turn off the scope from the handle, or they can store it in the cleaning device to prevent surgical fires or eye damage. Robot instruments Robot instruments with cautery collect burn tissue, so the surgical tech needs to clean them between use. So robotic cases are advanced laparoscopic cases, which laparoscopic instruments are replaced with endowrist instruments that can move more freely. Cases may have a portion where the robot is undocked to create an extended incision with a wound protector, like in colorectal cases. And sometimes the case is converted to open when doing it robotically is too difficult or during an emergency situation. Sometimes there's an additional assist laparoscopic port, and it's added where regular laparoscopic instruments can be used to assist the endowrist instruments. And this is what it looks like when the robot is docked. 3 of the arms are empty, but the third arm has a scope installed. There's an air seal trocar for insufflation under the 4 metal robotic trocars, and all the way to the right, there's an assist port for laparoscopic instruments. Each robot arm is reusable and has a lifespan from about 10 to 17 uses. When the maximum uses are up, they're considered expired, and a red dot indicator will appear on the bottom of the instrument. Here you can see up close the endowrist instruments. It's on a flexible joint that acts like a wrist, unlike a laparoscopic instrument, which can only rotate on one axis. We have endowrists for basically any laparoscopic instrument. We have needle holders, clip appliers, staplers, suction irrigators, tenaculums, and even some with cautery, such as scissors and graspers. So sometimes the instrument malfunctions and needs to be replaced. If it malfunctions while holding a tissue, it's very dangerous, so there's always a couple of sterile key wrenches stored in the robot tower or in the storage room in case of emergency. This is what the sterile key looks like. It's a sterile key wrench. So to use the key, the surgeon needs to press the emergency stop button. Then the circulating nurse has to open the key, and whoever scrubbed in has to take it and insert the key into the access hole at the bottom of the instrument. They'll do a quarter turn rotation to open the jaws, releasing the tissue, and the instrument will be removed and replaced. It's not safe to use anymore. So those were the nurse and surgical tech roles. Mike will speak about the other roles.
Thank you, Diane and Teresa. So let's talk about me instead of the robot. Come on. Okay, so why am I so privileged to be up here? For one reason is because 13 years ago, I was hired at Northshore University Hospital. I was given every opportunity to succeed, came here as an associate nurse, got my bachelor's degree, and then in 2018, I was accepted into the first program at Hofstra for their registered nurse first assist program. So I am the designated robotic first assist in addition to managing the robotic surgery program. So what does that mean as a robotic first assist? It means that I can do anything a surgeon can do under the supervision of a surgeon. So here in this video, you can see me about to place a port. So this video was recorded thanks to Dr. Shalom from Urogynecology. She's a big supporter of our robotic surgery program and myself, and I really would not have the success I have without her being one of my mentors here. She encouraged us to record this video for things like this. So what you just saw is me make an incision into the skin, and now I've placed a robotic laparoscopic port. I can place ports, I can suture, I can bring in Raytech. Like I said, I can do anything a surgeon can do under the supervision similar to a PA. Now, what are the qualifications or what do you need to get into RNFA school? There's 2 routes you can take. You can either go on the RN track, which would be you need to have perioperative experience for 3 years. You need to have your certification as an OR nurse. So you need to have your CNOR certification. And then, in addition to having a bachelor's degree, you can go to the RNFA program. RNFA program is a graduate certificate program. The other way you can go, which may be more pertinent to some of our non-OR nurses, is if you become an NP. If you're an NP, you do not need to have any OR experience. You don't need to have a certification as a CNOR. Once you have your NP, then you are eligible to apply and go to FA school. And you would then, once completing the program, you'd be an NPFA. So those are 2 tracks you can go. Hofstra has a program. I think they've put it on hold this past year. I think they're kind of redeveloping the program. RNFA is the rules associated with the RNFA program are governed by the AORN. So basically what you do in school, what we did at Hofstra, it's 2 semesters. It's 60 clinical hours a semester. So that's in the OR, like 3 didactic days. And then after 2 semesters, you're done with the program. There are online programs. You would go, one of our nurses right now is going to be going to Rochester for a few days. She'll do the didactic work there. And then when she comes back, she has to, on her own, find a preceptor. And then she'll do the 120 clinical hours with her preceptor. And then she will be an RNFA. There's no tests required once you complete school, but after you get 200 hours of surgery under your belt practicing as an RNFA, you can then take the RNFA certification exam. So those are the options for RNFA. Besides, as they mentioned before, besides doing things surgically, I'm helping with positioning the patient, helping the patient get into the room, helping at the end of the case. RNFA can take the patient to the PACU. RNFA cannot write orders, but can be involved in most aspects of the hospital stay. So as it relates to positioning, right? We're positioning the patient so that we're utilizing gravity to our advantage. So if we're doing a procedure in the foregut, let's say it's a hiatal hernia repair, bariatric procedure, we want to use gravity in our favor. So that means that we're going to position the patient so that they're almost standing up. So those are all abdominal organs, they go towards the pelvis. This way it gives us a lot of space up in the foregut to work. Anytime we talk about positioning, we always want to be considering nerve damage, DVTs, things like that. Any position it may be, that's what we're thinking about when we're positioning them. We want to pad bony provinces. We want to think about where these nerves are, and we want to prevent any injury to our patients. When we're working in the pelvis, we have a different position, right? So when we're working the pelvis, it's usually colorectal or GYN. So we're going to need access to the pelvis. So we put our patients in stirrups. The legs are separated off the midline about 30 to 45 degrees so we can get in between the legs, and the hips are flexed up anywhere from 80 to 100 degrees. That gives us access to the pelvis. For surgery, we need to get those organs out of the pelvis. So we're going to move our patients into Trendelenburg, 30 degrees. If you see 30 degrees in Trendelenburg in real life, you're going to think it's pretty drastic, but it's what we need for surgery. And our patients tolerate it, surprisingly. Some of these procedures can be 3, 4, 5 hours that they're almost standing on their head, but amazingly, probably with the help of anesthesia, they get through these procedures no problem. Now, one of the great things I think we have that's been developed over the few years is how we position our patients. It's on something called the ping pad. The ping pad is a foam pad that goes underneath the patient. It's strapped to the table so it doesn't slide. And when our patients are on this pad, as they perspire, the pad becomes tacky, and it really limits their migration on the table. It also comes with, you can see their arms are padded in purple padding, comes with arm protectors, so we're really padding all those bony provinces, padding their IV sites, keeping everything nice and neat. It's also nice because every hospital in the health system is using this ping pad. So what does that mean? That means we're saving the patient time under anesthesia because everyone is doing it the same way. Previously, before the ping pad, some people use brackets for the shoulders. Some people taped across the chest. Some people taped across the waist. Everyone did it differently, and it just wastes time. And one of my personal goals for my patients when they're in the OR is to reduce the time they're under anesthesia. We know that the longer you're under anesthesia, the greater the risk for complications. So something like this moves it along so our patients are not under anesthesia for that long a time because we position them when they're asleep. And I will say with this ping pad, we do not see any table migration. Prior to the ping pad, the patients, it wasn't uncommon for the patients to move, to kind of slide down the table. But with this system, it's really great. Like I said, saves times and it keeps our patients nice and safe. So we're making space in the abdomen for us to work surgically. That's great for us, right? The surgical team, we love it. We have all this room. But our friends in anesthesia, not so much. Because what's happening? All these abdominal organs are now pushing up against the thoracic cavity. And what is that doing? It's limited their anesthesia's ability to ventilate the patient, right? If all these organs pushing up against the diaphragm, they can't really expand the thoracic cavity. So before we drape the patient in this position, we do a little tilt test with them, bring them to 30 degrees, and we're looking at their peak airway pressures on the ventilator. How well are they tolerating the ventilator? Usually not a problem. Sometimes if it is, if they're a little bit older, if they have restrictive lung disease, if they're a little overweight, if they have large breasts, right? All that weight is pushing on their chest cavity. We can either manipulate the ventilator so it kind of delivers them so it expands their lungs, increases their airway pressures, and we can kind of change the ventilator settings, obviously with our friends in anesthesia. So we usually do get through it no problem. The other thing to consider with any of these positions, right? We talked about table migration, we talked about ventilation. When we're in these positions, think about when women are pregnant, right? The baby's laying on the inferior vena cava, that's reducing the blood supply to the heart. Well, same thing, we're pushing all these organs against the vena cava. Sometimes that will reduce the blood supply to the heart. We worry about when they're in that Streep-Trendelenburg position, their head is very low to the ground. So we worry about their face getting injured. So we're always patting their face with pillows to make sure nothing happens to them. And of course, all the other things, as I said, right? Calf compression, VTE, things like that. Once we get in this position and we're all set to go, and we drape the patient and we start the procedure, we're going to put gas inside the abdomen. We're going to put CO2 inside the abdomen. We're going to put 15 millimeters of mercury of pressure inside the abdomen. So what is that doing? That's also pushing up against the diaphragm. It's also pushing up against the inferior vena cava. So that can also make issues for anesthesia as well. But again, they're really good at what they do, and they're able to kind of give some medications, change the ventilator settings to get us through the procedure and get our patients through. We see when we are adding this pneumo to the patient, we see like patient populations with heart failure, valvular disease, COPD, things like that, kind of have more issues than our healthy patients, but again, not usually an issue. Myself, our nurses, our techs, our surgeons, our residents, our fellows, we all go to training at BioSkills over in Lake Success. We have a dedicated area in BioSkills in the cadaver lab, the dry portion of BioSkills, where we have a robot set up. They offer classes monthly for our OR team, for our residents, where they get a hands-on training. It's about 4 hours long after they do online modules, so they can touch the robot, they can manipulate the arms, they're taught troubleshooting, things like that. So it's a really great place for our staff to learn. A wonderful crew over there. Recently, one of our techs had headed over there to help out with robotic surgery. A lot of our PAs will help out over there to train with robotic surgery. And so it's a great facility. We've even done training with our Urogyn fellows. We made a fake mesh for them to practice suturing with in the lab. So it's a great place to get education for the robot. So what are the benefits of the robot? We're comparing it to open versus lap versus robotic, right? So one of the big benefits, obviously, is a large open incision versus laparoscopic incisions. Okay, well, open versus lap versus robotic, kind of the same. But it doesn't just end with the incisions, it's also the way the robot trocars are designed. So I don't know if you can see, there's a bold black line here. When this trocar is placed in the abdominal wall, this bold black line lives in the abdominal wall. And this is the fulcrum. This is where the robot is going to freely rotate on that axis. So when done properly, theoretically, robotic surgery is less painful than laparoscopic surgery because you don't have a dumb human like me twisting and torquing on the tissue, causing more trauma. So that's one of the benefits of the robot. Another benefit would be the scope we have. It's not just in the vision that the scope provides, it's in the other functions that the scope provides. So you can see here, we're utilizing the laser function on the robot. So what does that do for us? Well, if we inject the patient with a contrast medium, indocyanine green, ICG, depending on where we inject it and when we turn on the laser, it'll light up. So in this situation, we are getting ready to divide the colon. So we injected ICG IV, it gets taken up through the circulatory system, and we previously taken blood supply from the colon. So we want to decide, where do we want to divide the colon? Well, if you look at it with just the naked eye, here, it looks like it's a little dusty here. This might be a good spot. But once we turn on that laser and we got the ICG going, we can see this tissue is being the colon here, and when we put the colon back together, we're going to have a good anastomosis, and we're not going to have a leak because we have nice, healthy tissue full of blood supply there. It could also be injected locally, like we do in GYN. In GYN, we inject it into the cervix. It gets taken up into the lymphatic system, and when we're doing malignant cases in GYN, and we want to do staging and we want to gather lymph nodes, But it makes it much easier to see, right? So lymph nodes live in the fat, and they're there. You can kind of see them. It's a little bloody, but if you turn on that laser, boom, those lymph nodes light up, and you can see them immediately. So it saves time. It's less traumatic to the tissues. So we get the specimen that we need, and move on with the case. So that's one benefit of it. The other benefit would be the picture-in-picture feature, the Tile Pro feature. So what we can do is we can take any device that has a visual output, and we can connect it to the robot. So what you're seeing here is what the surgeon would see during a partial nephrectomy. During a partial nephrectomy, we're going to remove a portion of the kidney where the tumor lives. So the surgeon can connect scan image, so he has an idea of where to look for the tumor. Then he can connect the ultrasound image and run an ultrasound probe over the kidney while looking inside the abdomen, and he can then use his right hand, the scissor, to mark the border of where the tumor is. So he really knows exactly where he has to resect to take out the tumor. We can do that with any scope. Colonoscope, we've done it before to find a mass in the colon. We'll do it in urology when we're looking in the bladder. Maybe we're trying to do some work on the ureter. We need to see it in the bladder while they're looking down with the scope. And we get pretty creative with it sometimes. As some of you may know, we are currently working on our Center of Excellence in Robotic Surgery and in minimally invasive GYN surgery. So we're going up for our third accreditation right now. Last accreditation was in 2021. We're going to be having a site visit in February on the 7th for our third accreditation. Northwell Health is also a network of excellence, and we currently have 3 surgeons of excellence, Dr. Shalom, Dr. Winkler, and Dr. Gadaletta. And I just actually had a call that I found out I can add Dr. Bedrosian and Dr. Zimmerman this year. So we are growing and growing the number of surgeons we have. All right, we're at the point where you guys know better than me. Post-op considerations, right? Once they're out of the OR, we unfortunately don't have an idea of how these patients do for the most part. But these are the things you guys know about, right? So things like post-op hemorrhage, post-op ileus, pain, anastomotic leak, pain from anytime I go to the floor to do education, everyone seems to say these robotic surgery patients are happier than the usual laparoscopic surgeons. I don't know if that's something that you guys find, but that's something I hear often. And again, just the VTE considerations, post-op hemorrhage considerations, and that's pretty much it. Any questions at this point?